equipped as the province here to deal with it, and we will continue to have problems. So.
On behalf of everyone, thank you for.
Oh, thank you.
Thank you very much. I will go right ahead and introduce Dr. Finlay.
40 minutes, though.
Yeah, okay. I'll speed introduce you. Most of you, I think, know Dr. Finlay. She's a community pediatrician here in Vancouver and works here at BC Children's Hospital now in the Family Immunization Clinic. Thank you. You did your training, I know, in pediatric residency in Stanford and then fellowship in infectious diseases here.
Yes, I did.
Thank you.
Thank you. Now, how do I work this?
Just
so I hope people can understand me. I'm afraid I have an infectious disease, a cold that I picked up from one of my little patients, and it's my own fault because I wasn't wearing a mask.
Pray for me.
And I know it's adenovirus because I swabbed her. So
okay, we have to get rid of his.
Yes. Maybe while we're waiting, I could get that lovely, beautiful woman over there is Laura Moore Dempsey. Laura's working. We're very lucky to have her. She's a vaccine. What's your title, Laura? I'm afraid I forgot again. Immunization Program Manager working for BC Pediatrics. Laura has years and years of experience with public health, and then worked with Merck and with Novartis. So we're very lucky to have her. So the handouts you have, I don't know who the original ones. Was it you, Haven? Did you do the original, or was it Bill? Pardon? Todd. So Todd Sorokin did the original immunization schedules, and we update them every few years. Laura and I did the most recent ones with help from you again, Bill, right? And so there's one for healthy children, and there's one for special needs children. Embedded in my talk, hopefully the links will work. The links are really helpful if you bring it up, because then you can click on, like I can never remember the schedule for the MenB vaccine, so I can click on it and bring it up. There's also handouts regarding HPV vaccine, and those have been funded in part from Merck, so thank you. So,
Well,
I could just start.
who's good at this?
Who's good? Well, I could.
Because he said just click on. Oh,
click on it?
Let's try that.
All right.
It's not. Yeah, I got it on here, but it's not going on there.
I'm afraid I'm hopeless, so. This happened to me before once here, so.
That's what he said.
I've got to help him.
What if we do a slideshow? Isn't there anybody here that's used to this? Somebody that works at this place? Shoot.
Oh, here comes.
Here comes somebody.
Remember we just did that.
What did we do yesterday? Yeah.
Okay.
A journal club.
See, we have it here.
Someone was listening.
But it's not going to there.
Yeah,
Unless
so there's this button.
Oh, yeah, and it was. Where is it?
Journal club.
Yay! Okay.
And we can do
All right. So, and how do I advance?
slideshow, maybe?
Maybe just go like that. Okay, so I'm going to zip right along.
But that's got a whole thing.
So I have received lecture fees in the past, but nothing for the past year.
What should we do?
Okay, since I'm now the BC representative to the Immunization Committee, so which is very interesting. I took that over from Bill. So what we're going to do today is discuss some of the recent changes to the schedule, and I'm trying to incorporate some of the NACI guidelines and the NACI equivalent in the States, the ACIP guidelines, and save some room for some breaking news. You have to put your slides in so far ahead that I thought I would save some room for stuff that's new. So again, you've got your schedules there. Just a show of hands, how many people are now still giving vaccines in their clinics? So a few, yeah. That's good. Because fewer and fewer of us are actually. So some interesting things coming up is that Infinrix Hexa, so is given at 246 and then is now being licensed as a 2-dose primary series. So it's been licensed as a 2 and a 4. So we're awaiting NACI recommendations regarding this. So that would cut out the 6-month immunization, but it would bring the booster down to a year. So that would mean 5 shots at a year. But there may be we may be doing some stuff with MRV, but so that would be 5. So that would save public health quite a bit of money. And we know that Quadracel's no longer available. And so the kindergarten booster now has been changed to Boostrix IPV or Adacel polio. And how that differs is that has a smaller concentration of the diphtheria component and of the pertussis antigens, which is nice that you don't get the big local reactions. I remember my son, after his kindergarten shots, his arms swelled up like an egg. But, you know, immunologically, with pain comes gain. You know, if there's a good local reaction, you've got good T-cell immunity, which is what I tell parents. Yay. Though I must have, my arm sure hurt after the flu vaccine this year. But the problem is it might be potentially less immunogenic. Pertussis vaccine, especially as we've gone from wholesale to the acellular, it's not the great vaccine, right? Immunity starts waning within a year. It's so-so by 5 years, and it's pretty well gone by 10. So other provinces have been using this lower concentration for a while, and there's been no big upsurge of pertussis, but we'll have to keep an eye on that. We now have the 2nd dose of varicella vaccine for children in the kindergarten shots, and there's a school-based catch-up program in grade 6. And a couple years ago, they moved the 2nd MMR, which was given at 18 months, and they've combined it into MMRV at kindergarten. And you say, why don't we give it for the 1 year? And maybe we will. They do that in Alberta and other provinces across the country. It would get that 5 shots at a year down to 4. The problem is that there's a slight increase in febrile seizures when you, at that age group, not the older age groups, but at 1. And so I think they just don't want the bad press, you know. MMR causes epilepsy. I can just see the headline now. So it may come. And it certainly it is licensed, and you could offer it to families if you want. But I haven't had anyone take it. I said, well, I can combine the 2 down to 1. There's a slight increase in febrile seizures, and everyone said, no, they don't want it. Okay, what about for travel? We had a little girl come into Crossroads. She was 9 months old and been to the Philippines. And so she had not received MMR, and her chief complaint was mouth sores. So she sat in our waiting room for 2 hours. And of course, it was measles, it was Koplik spots. And it caused a huge kerfuffle because you've got to phone everyone that was in there for 2 hours after she left. You know, it's huge. So we learned our lesson the second time someone came around who got off the plane from China with measles, and that child was isolated right away. But just to remember that early MMR is licensed down to 6 months, and it is indicated for travel, but it doesn't count towards the final tally. So if you give it early, they still need their 2 1 year after. There's been a lot of measles in Europe, especially Romania. I finally got MMR into a patient of mine whose mom wanted to take him home to see grandma in Romania. So she perceived there was a risk, and she went ahead and gave the vaccine. So, and all is well. He's not autistic. So, mom said, actually, I tell the story. I have an autistic kid, and his mom always refused MMR. And she said, well, it's a good thing we didn't give him the MMR because then his autism would be worse. So, yeah. So mumps, we know there's been mumps around. And of the MMR vaccine, this one is the one with the least efficacy. It's about 78% after 1 dose and about 88% after 2. So we know that most of the people that are getting mumps are people young enough to not have had a natural infection. So people born between 1970 to 1994. And so people have actually not been vaccinated or haven't received a 2nd dose. but there have been outbreaks in highly vaccinated communities like the sports teams like Sidney Crosby, right? And so it is advised that people born before 1970 who haven't received the 2 doses to get one. And so this would include a lot of our parents in our practice. So recent changes to the adolescent crisis. Hallelujah. We finally have HPV vaccine program for boys here. They've had it in Alberta for a few years and across the rest of the country, because it was 2012 that NACI recommended it. So we're all very excited. So we've had the quadrivalent program for girls for a while now. And because of research coming from the Vaccine Evaluation Center, Simon Dobson especially, we know that if you get that first dose in the day before they turn 15, you only need 2 doses. And so when parents say, why the heck are you going to give this vaccine to my daughter? She's only 12. You can say, because it's stronger and it works better, and then we can get away with 2 doses. So I don't think that message is really getting out there. The 3-dose schedule, however, remains for girls who are older than 15 and immunocompromised. So the boy program started this fall. And why are we doing this? Well, we're going to have additional protection of girls because the uptake is only 70%. And, we just have to get the message out there that this is a vaccine for cancer. I mean, of the number needed to treat, to save lives, this vaccine is more and above any other vaccine, meningococcal, varicella, you name it. If this was a vaccine for breast cancer, those moms would be pushing their daughters in the door, right? But it's the yuck factor, and it's really disheartening. But I think we've got handouts through BCPs. I encourage you to take them and to get out the good news. So we vaccinate boys to help protect girls, and we vaccinate boys to protect themselves. So warts, genital cancers, and oropharyngeal cancers. And oropharyngeal cancers are skyrocketing, especially those due to HPV. The percentage due to smoking is going down because kids aren't smoking anymore. But with adventures in sex, oropharyngeal cancers are really going up and may eventually surpass cervical cancer, and there's no good screening, right? I know when you go to the dental hygienist, she takes a look, but there's no real screening for oropharyngeal cancers. And anal cancer in gay men, the incidence is higher than cervical cancer in the third world. Again, there's just limited access to anal colposcopy and screening. So the products available, cervix as a GSK product with this amazing adjuvant, covers the 2 types, 16 and 18, which cause 70% of cervical cancers, and 16 causes at least half of oral cancers as well. And then there's the Merck, which has the 16 and 18 and the 2 extra subtypes that cover warts. And then Gardasil 9, which has an additional 5 types, which give you additional 15% coverage for cervical cancer, and you can see the rest of the stats there. So people say to me, well, my daughter got the 4. Is it worthwhile giving her the 9? And I said, yeah, it is. You get pretty good immunity with even 1 dose. So yes, I do think it's a good idea to give everyone this 9 vaccine. The problem with the boys is there's no catch-up. So they're not going to catch them up in grade 9, which I think is too bad. You can only get caught up if in a sort of special group, like HIV, men have sex with men. You can see it there. People in custody, street involved. Now, you only have to say you're questioning your sexual identity. So, if you send your son down there, the bar is pretty low. I don't think they're going to ask. Like, I have a 26-year-old son. I said, why don't we just get the free one at the public health? You'll wear a pink shirt. He goes, no. He absolutely refused, but he's okay with me paying for it. Thank you very much. And a lot of our kids, if they go to university, there's a budget for vaccines. So you maybe get so you could get the first dose, in December, and you could get that one covered, and you get the second dose, and then maybe they'd have to pay for the third dose. So a lot of the there's a college fund, you can get some of these vaccines covered. So. And again, we've got the fact sheets through the BCPS. So, meningococcal vaccines, yeah, horrible, huh? So, the problem with not all of it came up. There's 5, or if you can count 6 medically important subtypes of Neisseria meningitidis based on the capsule. It has a polysaccharide capsule. And A, Y, and X are travel-related, and there's been an amazing decline in C. If you remember, in the early 2000s, there were outbreaks across Canada, including Abbotsford. And with the success of the vaccination program and herd immunity, we're not seeing much C anymore, even in people too old to be vaccinated. So now the biggest burden is B, especially in infants, and that's because the capsule is purely immunogenic. You can't make a vaccine from the capsule. And so what they've done is they've tried to make a vaccine against antigens that poke through the capsule. The problem is between the strains, those antigens vary. So there's been like a New Zealand MenB vaccine, but doesn't work in Cuba. The Cuba vaccine doesn't work. It's very, very strain specific. So this is too small, but this is, I got this from Monica Noss, BCCDC, so it's very recent data up into 2016, looking at the strains causing disease in BC. I did the math for the last 5 years. There were 57 cases, and of the 57 cases, half were B, 40% were Y, and the remaining 10% were split between W and C. And actually in 2015, 2016, there were no cases of C, but this year there's a case of C in a young woman who came to Canada after she would have received the immunization in school. So just a reminder that this vaccine is free for kids up until age 24. And whatever, it's in the fridge, just give it, right? And this is the age groups in 2016. You can see the big age group was in the 15 to 19-year-old age group, and those cases were evenly split between B, Y, and W. And just to say that in the extremes of age, I wouldn't call 40 extreme, but there's still cases of meningococcal disease, so we're not out of the woods just because we're not teens. So the program here for healthy adults, healthy children and adults, includes Men-C at 2 and 4 months. And they were given Men-C again in grade 6, but that's now changed to a different product at a later grade. And we're using Nice-Vac-C, and we use that one as a tetanus toxoid because it's the best immunogenicity in babies. And we also now have a quadrivalent program, and we're using Nymenrix. That product got the contract, and again, it's a tetanus toxoid. So it's funded for grade 9 students. For high-risk children, Menvio, which is a quadrivalent conjugated to CRM, that one has the best immunogenicity in the small infants, or at least the ones that's been most studied, and it's licensed down to 2 months. So people who are traveling, this vaccine is licensed for them. And I have families come in, they're very worried about meningococcal disease, so they want the B, and also they want the quadrivalent program, so we can come up with a schedule for them. It costs quite a bit, but they're happy to do it. Meningococcal immunity doesn't last very long, so it has to be boosted quite frequently. Menactra's licensed down to 9 months, and Nymenrix down to 12 months of age. But they've got some infant studies pending. So the challenge of B disease. So we know that the greatest proportion of meningococcal disease is B, especially in the babies. 85%, especially in the under ones and especially in the under 6 months. So moms say, oh, well, if I wait to give men B until they're a year, I can save myself some shots, right? Yeah, but your highest risk is in early infancy. So like in England, I've been giving it at 2, 3, and 5 months if people are really, really worried. But in England, they just give 2 shots in their primary series. So the meningococcal B vaccine we've had for a while here is the Bexsero. It's a 4C-Men-B. It has 3 recombinant surface proteins, including a factor H binding protein and another outer membrane vesicle protein, POR-A. And it's the POR-A that makes this vaccine so reactogenic, everyone with sore arm and fever. So this vaccine was licensed in 2013. Now they estimate, again, there's so much strain variability that 2/3, maybe more, of the strains will be susceptible. And it's been used successfully in a Quebec outbreak in the Eastern Townships. So Pfizer now has approval for their meningococcal B vaccine, and they're using 2 purified factor VIII binding antigens. It's been used in the States. It's licensed to those down to 10, and they have infant trials ongoing. Now, I know the Pfizer guy's here, but he said, what percentage of strains do you think he's going to be covered? He said, 98%. Go, wow, that's really great. But I'm going, that sounds too good to be true. So I actually asked Julie Bettinger, who's with the Vaccine Evaluation Center. She says, no, she doubts it's going to be that high. And she reckons both vaccines are going to be between 2/3 to 90%, depending what's circulating at the time. So if there is a big outbreak, they'll characterize it and they'll see probably which vaccine has the best fit and use that one. There's no head-to-head comparison with Bexsero, and this one is expected in Canada sometime in the spring, I think. So right now, with the Men-B vaccines, it's very limited availability. It's provided free to a case of Men-B or potentially an outbreak situation. Is recommended by NACI for those people that you would also recommend the quadrivalent meningococcal vaccine, but it's not funded here in BC, though it might be. I think it's coming up. It's on the wish list to fund this vaccine for immunocompromised individuals. It has not been recommended NACI routinely for routine use. Flu. So this year, there's some changes. So they've changed the H1N1 component. The H3N2 component is the same as last year. And this is the same component that was used in Australia with quite dismal results, to tell you the truth. H3N2 is a difficult antigen because from what I've been told, what you put it into the egg and you grow it up, it changes. So what you put in and what you get out are not the same. And there's a lot of variability in the strains. So in Australia, they found very poor efficacy against this particular strain, and down to 10%. And there's also a B strain, and in the quadrivalent vaccines, there's an additional B strain. I think this is too small, but just to say that the tetravalent vaccines are preferentially for kids under 18 because B tends to hit this age group harder, but they are licensed in older age groups. I think it's rather silly that we're not using a quadrivalent vaccine in a children's hospital, but there you go, it's more expensive. I gave myself the quadrivalent vaccine. Anyway. And there's for the elderly, over 65 is hardly elderly now that I'm getting closer, but there aren't any of the Fluad. Fluad was the adjuvanted influenza vaccine, so it's not being used this year. So one good thing this year is you don't have to worry about egg allergy anymore. So it's not contraindicated. You don't have to give the half dose. You can use it as give it as usual, but with the advisal that anyone who receives a vaccine should be counseled accordingly, observed for a short period of time, and you should have the ability to have epinephrine in your office. And I think Antoinette had a case of anaphylaxis in her office, right? Yeah, I said it was pretty terrifying, but all was well because she was prepared. Yes, but it's so rare, but so it can happen. You can have anaphylaxis. Now, people keep asking me about flu mist. I've heard that Burnaby has flu mist. We don't have any. We don't even have any. You've got flu mist? Okay, so it's starting to come through. So they didn't buy much flu mist this year because last year a lot was wasted. People were feeling that it wasn't, it's not being used in the States, so we're not going to use it either. And certainly in the States, 2 years in a row, it had very poor efficacy, especially against H1N1. In the Canadian studies, it wasn't as bad. It was slightly worse against H1N1, but it performed okay against the other A strain and against the B strains. And I did check with Danuta Skoronsky, who's the flu diva, and she said that last year there were no signals that the vaccine wasn't working well, but then it was an H2N3 year, so there wasn't a lot of H1N1. But the official word out there is it's equivalent to the injectable vaccine, but that NACI, though, has taken away the preferential. They used to say it was better in the 2 to 17s, but now they're saying it's equivalent. So again, a little bit more about the efficacy, but I'll just go over that. The efficacy against the H3N2 is low. Okay, so the privately available flu vaccines you might have had, well, we're pediatricians, we don't get them marketed, but the high-dose Fluzone, so it's, just has more of the antigen in, and it does seem to be more effective. So this trial compared the same product, the normal Fluzone versus the high dose, and it was more effective. There's a sort of a soft recommendation, the NACI statement, saying it should provide superior protection, but they don't make an absolute preferential recommendation. So what's with new in adult immunization? Well, the big area of controversy is pertussis vaccination in pregnancy. So in the States, they're vaccinating every woman in every pregnancy. Again, the immunity to pertussis vaccine doesn't last very long. And certainly in California, they have cut their rates of pertussis in very young infants by half. So it's been successful. So NACI, we don't have the numbers to support that strategy right now. So NACI is just recommending if that woman has not received DTaP in adulthood at some point to give it. But in BC, it's not funded. Pneumovax. So Pneumovax is a 23-valent pneumococcal vaccine. It's free for immunocompromised and everybody over 65. A new indication is moderately severe asthma. And I did ask my respirologist, are they giving this to the kids in their severe asthma clinic? And they said no. So remembering that pneumococcal disease is a U-shaped distribution, so the very young and the very old, but actually starts going up after about 49, so you don't have to be that old, especially if you have comorbidities. So if you have a diabetic who has asthma, who has COPD, the comorbidities increase your risk exponentially. Okay, so we know that it's not a conjugate vaccine. You don't get complete immunity. It's T-cell dependent. You don't get good antibody titers in your nose. It doesn't decrease carriage. It doesn't decrease it's not very great against non-bacteremic pneumonia. So it can still have the bugs in your oral pharynx and aspirate them down into your lungs and get pneumonia. So Prevnar 13, the conjugate, it's provided free to adults with HIV or those who received stem cell transplants. It's recommended by NACI for quite a lot larger population than that, including all those people who are on Remicade or, all those biologics, right? And other provinces are, and it includes steroids, other provinces are using a much broader indication, but not here in BC. What's got some people excited, especially Americans, is a huge trial in Holland, where they don't have a pneumovax program. They found that it was effective against vaccine type of pneumococcal pneumonia. So it sounds great, but there was a 4% decrease in hospitalizations for pneumonia overall. So 4%, well, 4% is 4%. I guess on a population basis, that would be significant. So in the US, you get your free Prevnar when you turn 65, followed by pneumovax. So you have to give the 13 first and then the pneumovax. Because if you give the pneumovax first, it'll decrease the response to the Prevnar. So if anyone just remembers 13 first and then 23, it'll be great. So the NACI recommendation just says to look at it on an individual basis. So, okay, I certainly got my Prevnar. I'm asthmatic. Okay, so what's the big news, I think, is the new shingles vaccine. So this is going to be a game changer. So we've had the Merck vaccine for quite a while. It's Zostavax, which is a live attenuated vaccine. So it's like 15 times the titer of the varicella vaccine. So now GSK has a non-live adjuvanted subunit vaccine. So it's using that amazing adjuvant that's in Cervarix. So it's about a 30% efficacy higher than Zostavax, with a more than 94% reduction in herpes zoster, regardless of the age of immunization. So even in the 80-year-olds, they were seeing a 90% reduction in shingles. So I think it's amazing. And in the product monogram, it says excellent protection up to 4 years, but now there's data out to 9 years. So this will be coming out in January here. Canada's, I think, one of the first countries to have it. And it'll be indicated for adults 50 up, including immunocompromised. So it'll be interesting to see how this product gets used in the subspecialty clinics. Big side effect, those real sore arm and feeling crappy for about 4 days. But again, immunologically, with pain comes gain. Okay, I'll just take a sip. So the breaking news is now the Family Immunization Committee clinic is open. So this is a space in the Ambulatory Care Building just past the Starbucks. This space has been used for the past 3-4 years for flu. But as soon as the flu campaign winds down, we're going to open it up for immunizations of other types. So, and we don't want to replace public health, but I be nice for those clinic patients that maybe need their pneumovax, or we've been seeing people who are going to go on Remicade and need to get their vaccines updated before they become immunocompromised. We're happy to see those vaccine hesitant patients, or perhaps those patients who their parents perceive have had an adverse event around the time of immunization, and actually they get enrolled in a research study. So I've just been working there for a few weeks, and I'm really enjoying it, and I'm really having a good time. So I'm learning so much. So anyway, so that's all I have to say. So thanks for putting up for my throat. So any questions? We have Laura here too, so the Real ID doc can answer any questions. Yeah, Michelle. For flu, it's walk-in. Right now, for the extra vaccines, I think the plan is eventually it will be walk-in. So that's coming. For the counseling and try to the immunocom, that's by appointment. So on Thursdays. Yeah, Antoinette. Oh, thank you.
I think I'm missing that 6 to 12 month is that should get an MMR and the travel.
Yes.
Is there travel anywhere outside of North America, or there's certain places that we're looking for it?
Well,
or a map
The official recommendation is traveling anywhere outside of North America, but then Disneyland was a hot spot, right? Yeah.
Really, so everybody is,
Well, but there are hotter spots like Italy, France, Europe. Laura, do you have any ideas on that?
Well, the other one that I would think of is China.
China, Philippines.
Cases of measles in Canada
Yeah.
are associated with travel to China. So
Yeah.
I would recommend going to China.
That's a huge number of people, yeah.
And then probably Africa. Probably, yeah. India as well is probably.
So the whole world, huh?
Yeah.
pretty much, yeah. And then we just catch up again just that with their 1 year.
Yeah, so it doesn't count. So you just have to start all over again. I think Sean had a question.
So what's the new family immunization? We have children that want to catch up.
Well, ideally they would go to public health if they're straightforward.
Right. I have a couple of kids that are hyper-anxious, and I've had to do them in the NICU in the past.
Yeah, that would.
But now I can't do them in the NICU.
Okay, well, that would be an appropriate. I mean, I get to triage them, so don't worry. My bar is pretty low because we're not that busy yet, but I expect a deluge. Sorry, Debbie?
I find the routine immunization that sheet pretty helpful, but one of the things I find is that I lose my memory of when things were introduced. It would be nice to have a historical dating of when things were
Yeah.
looking back at this.
I agree, because I came up with that with, like, when did we go from Prevnar 7 to Prevnar 13? Because a lot of those older asthmatics have not received the 13. And I just Googled it, to tell you the truth. When was it introduced? It was 2010. So those older asthmatics haven't had that. And I think it would be more than reasonable to give them the Prevnar 13 and then before you gave them the 23.
It would be nice to have a listing on our website with things.
Okay. It's getting pretty crowded, but maybe we could have a link. Bill?
So you've got over teenagers, let's say, who receive their full Gardasil series of water filler. And you want to bring them up to non-available, how many doses?
Well, if they're over 15, they're 15 and up, ideally 3, but at least 1. 1 is better than none. 1 is actually not too bad, but the official would be 3, yeah. You don't need that $450, right? Cheryl? It's just now. Yeah, this I think when it's maybe a few months ago. In the public health clinic, I think this year, but just in the school this September, yeah. Okay, thank you for your attention.